plenty of time to finish your paragraph. Find your seat. Welcome to the summer 2017 Distinguished Levitt Lectureship. It's a privilege for me to welcome you here. And I think you've got a real treat in store for you. Louis Levitt was born in 1896. He went to vet school, so he was a vet. He graduated from vet school in 1920. Then he went to the University of Colorado Medical School, from which he graduated in 1927. Practiced as a general practitioner and a vet in Denver for 40 years until 1967, at which time he retired. When he died in 1978, he had bequeathed to the Department of Family Medicine an endowment for a lectureship, which we have used to good effect. We've had over 60 distinguished speakers come to this campus to talk with us about things bigger than we're ordinarily thinking about. They've edified us, enriched us, educated us, inspired us. And today is going to be no exception. One of our proudest, my proudest opportunities to welcome a Levitt lecturer is here today, Ned Calonge. Many of you know Ned. He's a local boy. We often invite people in from out of town. Ned is, you'll notice the letters behind his name when he eventually gets around to putting them up. They say MD, MPH. And too often, when you see MD, MPH, the MPH part is an asterisk. It doesn't really define very much of how that person thinks or operates. This is not true of Ned. He is an honest-to-God, public health, public policy, community-oriented clinician who thinks and lives and works in both worlds to good effect. Ned, I'm going to just tell you a few things. I could literally spend the time bragging on Ned, and that would be fun for me, but it'd be a real drag for you because you'd miss out on something that's really going to be a treat for you. But Ned has an interesting career. Right now, he's the president and CEO of the Colorado Trust. You'll hear a lot about that, so I'm not going to define many of the features of that, but this represents the fourth major health sector that Ned has worked in during his career. He started out in an academic setting here at the University of Colorado. He was, and in fact continues to be, a member of the faculty in the Department of Family Medicine. He worked as a clinical and services and policy researcher back in the days when we were trying to figure out how to do practice-based research. He had a lot to do with sorting that stuff out. He moved over to Kaiser, where he not only worked as a researcher there, but also messed with their health system. He began to work with and understand how systems of healthcare work in Kaiser. Then went to work in the government. He worked downtown in the state government. He was the medical director. Think of him as the state health officer through several governors. He made it on both sides of the aisle without getting fired. That itself tells you something. I'm not sure exactly what, but he was the medical director for CDPHE downtown for quite a while, and then he went to work for the Colorado Trust. Ned chaired the United States Preventive Services Task Force, the USPSTF. This for if there's anybody who's been living under a rock and you don't know what that is, this is a precious resource in this country that produces exquisitely scholarly, researched, and evidence-supported recommendations about prevention for the U.S. Some of their recommendations have been incredibly controversial. And Ned has to stand up and take the hits on all of those. So he's done that. He's chaired the USPSTF. He's a member of the National Academy of Medicine, used to be the IOM. He sits on the board for population health and public health practice there. And he's He's been a member of and a co-chair of a number of the committees that produce reports for the NAM. He's also on the board of Community Preventive Services, the Task Force for Community Preventive Services at the CDC. And there's a lot of other stuff like that. You get the idea. This is a high-profile guy. He knows his smoke. He knows what he's doing. So whatever he says, even if you don't like it, even if it doesn't square with your prejudices, you better take it seriously, and you'd probably be better off just believing that it's true, because it is. I'm proud to introduce to you Ned Calonge. Ned?
So, I'm trying to figure out how I'm going to live up to that introduction. I was thrilled when Frank asked me to come and talk about what we're doing at the Trust. Because this is my true area of passion, and you know, one of the biggest blessings you can have in life is to be able to actually work in your area of passion. So I'm going to talk today about health equity and try to broaden some of your views on health and what is health on a broader basis. I'm going to try to tell you why the Colorado Trust isn't working in health care, which is where we worked for years and years in philanthropy and gave lots of grants, and why we're moving why we've moved in a different direction, and why we're taking a really novel and innovative approach to how we're going to fund and address philanthropy. So titles are always the worst part. I really like it when someone gives me the title and then I write the talk for it. So I actually had to come up with this title, which is why it's long and kind of boring. But I want to talk about how we're addressing health equity through philanthropy, talk about our three funding areas: data, advocacy, and community partnerships. And to set that up, I want to give you some background in why we think this is important. So the first thing we have to do is define terms. So our catchphrase, our tagline is a health equity foundation. And that took a lot of time to get put into place because we're old school. And we had to work and think about how it was going to come off. And one of the criticisms is, well, what's health equity? No one knows what that is. And we picked that intentionally so that you would say, well, what's health equity? Because that is a learning and awareness building opportunity. And you guys didn't ask the question, but you're going to get the answer anyway. So you have to define the terms. And there are three key terms: health equity, which is a parent term, and then two child terms: health disparities and the social determinants of health. I'm going to tell you how the Trust defines these. There are definitions all over the place, but we've tried to take ones that have some panache and have a lot of other smart people working on those, and that's what we're going to do. So health equity is attainment of the highest level of health for all people. It requires valuing everyone equally. Very important phrase. Now, equal and equitable are different phrases. I'll make that pitch now. If I wanted to create equality, I would give everyone the same thing. If I want to create equity, I give people what they need. So giving everyone a pair of shoes is equality. Giving everyone a pair of shoes that fits is equity. And so this is actually talking about equality. So health equity requires valuing everyone equally. Everyone has the same value. Focused on ongoing efforts to avoid avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. That's a pretty lofty goal. Healthy People 2020 helped me out with that, and that's kind of the way we embrace it. Health disparities, on the other hand, it's a particular type of health difference. Now, if you look at the NAM's definition, it just says health differences. This is a Paula Braveman definition. It's differences that closely linked with social, economic, or environmental disadvantage. So it's a social justice definition of health equity, which to me brings up where we're working in the spaces we're trying to work in. And I think it's very important. They affect groups of people who have systematically experienced greater obstacles to health based on their race or their ethnicity, their religion, their gender, their socioeconomic status, how old they are, and a number of other factors, traditionally and historically linked to discrimination or exclusion. So that's a little different from just saying differences in health. It's with that kind of social justice lens. Well, here are some example of health disparities in Colorado. So this is a made-up young woman, 6-year-old Isabella, Latina, born in Colorado. And the numbers are not fictitious. These are based on information from the Colorado the Colorado Department of Public Health. And so at age 6, Isabella looks forward to these disparities. Her risk of obesity is 50% higher than her Anglo classmates. She's in first grade. 40% higher risk of diabetes, 3-fold increased risk of diabetic mortality. And when you think about that increased risk of just getting diabetes isn't that high, but the mortality is much greater. 20% increased risk of stroke mortality, 30% risk of not getting breast cancer screening as recommended, 2-fold increased risk of cervical cancer, 3-fold risk of teen pregnancy, and when she does get pregnant, the odds that her baby will die in the first year of life is 50% greater than her Anglo counterparts. This is Rebecca, African-American, 6-year-old in kindergarten, born in Colorado, and this is what she looks forward to. And you see a similar list: obesity, diabetes, now high blood pressure, stroke mortality, cervical cancer, 75% increased risk of cancer mortality independent of the incidence of cancer. 25% risk of teen pregnancy, and a shameful and persistent 3-fold increased risk of having her baby die in the first year of life. This is a disparity that's present across the country, and it's a little bit worse here in Colorado. There is no biological reason for these differences. I want you to hold that thought. There are lots of other health disparities. I just listed everything that we found with state data around things like infectious disease, especially HIV, homicide, liver disease, teen fertility, suicide. You can go on through major health conditions, and they're negatively impacted in different populations. So I want to move on to the social determinants of health. And these are the circumstances in which we are born, we grow, we learn, live, work, age, and all of the systems surrounding us put in place to deal with illnesses. And then you think about what determines those. And it's this broader list of things: economics, social policies, and politics. So I try to break down the social determinants into categories. And the first category is kind of the education category. So early childhood development, schools, education, and literacy, including health literacy. And then there's kind of the work, income, and wealth. There's economy, jobs, employment, occupation, working conditions, income, and wealth. And then there's the kind of Maslow hierarchy things, right? The basic infrastructure for life: housing, transportation, safety, parks and recreation, access to healthy foods. And then this kind of unusual social context of racism, social status, culture, social network, political clout, and justice. And when I say racism, I'm really trying to use Camara Jones' definition, right? Which is, there's lots of definitions, but I cling to that one because it kind of makes it a little bit broader and talks about the differential distribution of resources based on how a person looks. And I would charge anyone in this room to not say racism is incredibly prominent in terms of overall health in people in our country, in our state, in our city. Social status, culture, network, political clout, and justice. And then finally, the bad things that are in our environment. So I don't want to talk about the administration. So I'm skipping, I'm going on. This is my oh my God slide. And I apologize, but it's so important to me. There are other people who have simplified it. I like the version from Bay Area Regional Health Initiatives. And they talk about this spectrum of health from upstream and downstream issues and impacts. And so if you kind of look at this side of the slide, these are all the social determinants, and we really don't get into health until this end. And I'll just tell you, that's really far downstream. That's like the story of the cliff, right? There's a cliff, people are falling off the cliff, they're getting hurt, and the community says, we need to do something about this. And so they build ambulances and hospitals to take the people from the bottom of the cliff to the hospital. No one thinks to build a fence at the top of the cliff. Upstream, downstream. And so you look at things like social inequities around class, sexual orientation, sexual identity, immigration status, race, ethnicity, and then you think about our power institutions, our schools, even our nonprofits, government agencies. You think about the living conditions that impact our health, and then you get to our behaviors, and then you finally get down to kind of healthcare and mortality. And all along the process is public health, and all along the process is policy. So I always pause to ask the question, because I get this a lot. Well, what if we just improve things for everyone? What about equal opportunity? If we just make things better, won't it help everyone? Won't a rising tide lift all boats? And I'm going to tell you, that's a failed concept. So I once said in front of a friend of mine, the problem is that some boats are more heavily laden than others. And he answered, and some people don't have a boat at all. We have to have intentional focus on the social determinants of health, and we know those affect different groups differently. So I'm going to make my pitch to you. Why health equity? Why now? Let's start with economics. This is a study done out of the Joint Center for Politics and Economic Studies by a researcher, Brian Smedley, who's now working for Virginia Commonwealth University and RWJ. And they did a study of the economic burden of health inequalities in the United States. It's a fascinating read. I think it came out in 2007. And they looked between 2003 and 2006 and said, you know, a third of the direct medical costs for African American, Asians, and Hispanics were due to health inequalities. Eliminating those would have reduced direct medical care expenditures by $229 billion over that 3-year period of time. So, you know, $1 million here, $1 million there. Doesn't sound like much. You get into the billions, so we're talking about real dollars. When they look at the cost of premature death and the opportunity costs and the workforce that we lose, the estimates go up to $1.24 trillion. It'd be nice to have that money back in the healthcare system. Why now? Well, there's some important demographics of our country that we should be paying attention to. This is the decadal growth rate. Only a demographer would get interested in something like this. But this is how much our population is growing by births in the different years and different race and ethnicities. And you see that whites, this is our growth rate for the decades listed, and we're just not reproducing very quickly, less every year. And then you look at all of our other members of our diverse country and our communities, and you'll see that their decadal growth rates are much higher. And so there has to be an outcome for that. So this is a 2010 percent people of color by county. So a study done by Policy Link. The orange counties are tipping point counties that are 40 to 50% people of color, and 50% we would call, it's a misnomer, but we say minority majority, right? But it's where greater than 50% of the people of color are. Well, look what's happening in the next 30 years. The country is changing its tone, its color. We are in the move, in a real change in our diversity. And it becomes important because I'm going to show you that a lot of the inequities and the social disparities are impacted disproportionately by race and ethnicity. And if we don't figure out how to address and embrace our difference, things will get much worse. Stephen Wolf, VCU, did this analysis back in 2004. He's not updated it, but he just looked at what if we just resolve these health differences? What would it mean over time? And so the top line is the mortality for black males in that time period. The next line down is white males. Next line down, black females. Next line down, white females. And you see a gap, right? And that's a mortality gap every year. And all they did was count up the number of deaths that are in excess for no biologic reason and came up with, over that 10-year period of time, 886,202 deaths that would have been postponed, averted from the years in which they occurred. Here's Colorado in 2010. I picked 2010 because it's our last recent census, and I'll change the slide. We're still pretty white, but the Latino population is increasing. It's at 21%. African Americans about 3.8%, and you see the rest of the groups. We are changing as well. This study takes our demographic shifts up through 2040, and you see the growing importance of our Latino population as we move forward in time. And if we do the policy link analysis, again, here's Colorado. I'm sorry that the light-colored counties don't show up so well, but this is today. So we do have one majority minority, or actually majority Latino count at 3 areas in the state. Interesting that 2 of those are persistent poverty counties, where they've had a higher than normal poverty rate for more than 30 years, right? 2 of the poorest counties in the country, in the San Luis Valley. And then you see how things are changing by 2040. So this is a Colorado issue, and one that we need to figure out how to embrace and how to become inclusive and a more united, cohesive society. All right, another social determinant is health and education. And education is fascinating to me because the more I learn about it, then the more I realize what a huge driver it is for overall life expectancy. Here's the logic model that Edgerton put together in 2011 and says this is how education impacts health. So the top one is just kind of not to do bad things, right? And the middle one is that you actually have an income and you can avoid stress and hazards, and you have housing and all the other things. And then the lower one is really those social factors like sense of control, social standing, and clout, ability to impact life. So that's kind of the logic model. It ends up that our best data are around income. So I'm going to kind of, don't lose sight of the other parts of the argument, but we'll focus in a little bit more on income. Let's just start, though, with self-assessed health status. So at one point in time, we realized if you're going to try to predict how much money a person would cost and you wanted in healthcare, and you wanted to use one metric that had the most explanatory value, it's this question. Your self-rating of your health compared to others. And what you see is that it varies widely by education level. So that the group that are fair or poor increases with decreasing education, and the excellent and good does the opposite. Similarly, let's look at another outcome, such as death rates. So these are death rates for all causes, chronic diseases, injuries, and really looking at males and females. And then on the axis, the colors relate to how much schooling you've had. So the blue, the tall bars are less than 12 years, and the little green bars are 13 or more, so high school graduation and beyond. And 12 is high school graduation. So this is an interesting issue. It leads to the conclusion that the biggest single predictor of how long a person lives in the United States, again, you can only measure one thing, is did you graduate from high school? It's a really important milestone. Here it is. This is a new study done by Robert Hahn, who works for the Community Guide at CDC. And it shows two things. The log odds of mortality based on education, and the slants are the directions I told you they'd be. So the less education, the higher your odds of mortality. And then you see that it continues after high school, and then you see the gap between the two lines. That's the importance of a high school diploma. So it's not like you learn a whole lot more in that year after you graduate from high school, so it's not the knowledge. It's the actual, I graduated from high school. What do we look like in Colorado? So I did this analysis earlier this year. This is 2015, 2016, high school graduation data from our own Department of Education. And we have variation. And these are important variations by race and ethnicity. I'll return to Stephen Wolf. Steve likes to tell us how things would turn out if we did better. Right? So here's Steve comparing if we just got educational attainment the same for all people across race and ethnicities compared to deaths averted by medical advances. Medicine doesn't stack up very well compared to education. And I'll kind of come back to this. This is why social determinants are so important. I've meant to ask Steve, why the dip in 1999? It looks like a particularly bad year for medical advances. I always forget to do that. All right, let's turn to income. So here's the logic model, if you will, but more in quotes, about why income is important. Wealth can have mechanisms such as power, prestige, attitudes, behavior, and social capital. So how money ties to social issues. Evans and Kim talk about the environment. So multiple physical and psychosocial risk factors, poor housing, neighborhood quality, pollutants, toxins, crowding, congestion, interpersonal relationships. And then Steve Wolf comes down to, boy, can you get the health care that you need? So these are three kind of ways that intertwine that income impacts health. Does impact, oh my gosh, I want you to look at this slide and just think about it for a while. So this is Chetty in 2016, pretty important article. And what he's showing on the household income percentile, or one percentile is about $1,500 a year. And then he's showing the life expectancy on the other curve. And women are on top and men are on bottom, and then the dark line is the average. There is a linear relationship between how much you make and how long you live in the United States. The gap in life expectancy between the richest and the poorest, 1% for men is 4.6 years. It's compressed for us because, you know what, we just have bad behaviors. And then for women, 10.1 years. He found that place matters. So it's better to be poor in San Francisco than it is to be poor in Birmingham. So the gradient's the same. That linearity persists. But if you're in San Francisco, you start in a higher spot. Right? You do better. And over time, some areas are getting worse and some are getting better. African American men living below the poverty status had a 2.7 times higher risk of mortality than African American men living above the poverty status, while white men above and below the poverty status had about the same longevity. And then African American women living below poverty status were worse off. So what does Colorado look like? I'm going to show you 3 slides, and I'll have to orient you to whether a high bar is good or bad. So this is the unemployment rate, so a high bar is bad. And again, you see how it varies by race and ethnicity in your home state. And these are really significant numbers. Now this was 2015, and now our unemployment rate is supposed to be somewhere around 3%, but you know that it's going to be lowest, right, in the white and Asian, and then differentially high in the other groups. This is median household income. So here, a high bar is good. And as you might expect, it kind of mirrors the patterns that we saw in employment. And finally, here's poverty, where a high bar is bad. And you can see the remarkable racial ethnic disparities associated with poverty in our home state. I'm trying to make this pitch that this is not an issue of the South. This is not an issue of border states. This is Colorado's issue. Galen in 2011 tried to do a multiple linear regression, trying to look at how many deaths are associated with different social factors. So I'm trying to summarize the previous things. Top one is low education. 244,526 is about the number of deaths avoidable through better care for cardiovascular disease. The major killer of Americans. Poverty, 133,000. Low social support, 161,000. And then there are area factors around poverty, income inequality, and racial segregation. So these social determinants directly determine our health. This is a famous, again, it took me a while to figure out that Steve Wolf actually did this work too. He did it for a specific project. And does anyone recognize the colors? This is the Metro map for DC. So at the end of the terminuses are the where the suburbs are. And then they all, end on the other end in DC. And what he did was look at life expectancy between the DC terminus and the suburban terminus. And showed that, where you live makes a huge difference. These are, they say 8-year, 9-year life expectancy disparities. I want to put that, like a 9-year disparity, into perspective for you. Actually, I'll do it with the next slide. So he came in and did it just a couple of years ago in Denver. I'm going to bring it home a little bit. This is a lot of your home city. And so the dark blue are the people who live a long time, and the light colors are life expectancy down at the 73 range. And you can see there's a number of those in our city, and the difference between the longest living communities and the shortest living communities is 11 years. That is the same life expectancy you lose from being a lifelong smoker. That's huge. Regular mammography, starting at age 50, provides you about 3 months of life expectancy on average. And what resources do we put into that versus trying to address these issues? You can drive this, right? You have driven that. And in the span of a 15-minute drive, you will span 11 years of life expectancy. All right. Do I got your attention around social determinants? Do you see why maybe the trust moved away from healthcare and more to health equity? What I've tried to show you is why. And it's why I will tell you we're not funding things like Rural Health Track. Great program. I firmly believe in it, Frank, and I'm glad you're doing it. Right? Or undoing the opiate addiction with treatment and prevention. Fantastic program. And we're trying to work a little farther upstream. So we're dedicated to achieving health equity. We think we need to have fair and equal opportunities to lead healthy, productive lives regardless of race, ethnicity, income, or where we live. That phrase looks innocent enough, and I'm sure you could take exception with how we phrased it, I would tell you that blood was shed over every word. So we're trying to say equity without saying equity. So that's where fair and equal comes from. It's the best I could do. We could do. And then race, ethnicity, income, and where we live were chosen as the biggest drivers of health disparities in our state. Race, ethnicity, poverty, and geography. It doesn't mean to leave out really important things like disabilities, ageism, and gender identity, and veteran status. All of the modern isms that we know impact life expectancy and how people are treated. But we really said, we don't want to have that whole phrase. Let's make sure we lift up the ones where we know we have the biggest problems. Good health depends on where we live, the education we receive, the work we do, the wages we earn, and our opportunities to make decisions that improve our own and our family's health. Those were carefully picked words. There's a conservative feeling about opportunity, and that everyone has the opportunity to be healthy. And the bottom line is that we don't all have the same opportunity to make the choices to be healthy for us or our families, and we need to work on that. Then finally, partnering with communities, we can advance fair opportunities for all Coloradans. So here was a learning from me. I'm not happy about having to take this learning journey, but this is a theory of change. And theory of change is the way philanthropy organizes its work. Now you might say, Ned, that looks like a logic model. Another thing I'm not really excited about. But I've grown in my position. It's different from a logic model in that you start here and say, what has to happen for us to achieve that? Rather than saying, these are the determinants that if you follow them, end up in that outcome. That's a very simplistic difference. It's sometimes lost on, but it is what it is. So this is our theory of change, where our strategies are in 3 areas, and that's what I'm going to spend the rest of the talk talking about: policy and advocacy, community partnerships, data and information. The intermediate outcomes is that we do better jobs at policies, we have data systems to look at inequities, and communities can act in a manner to advance health equity. Long-term outcomes is we reduce disparities and improve social determinants of health, especially in vulnerable populations, and the vision is that we all have fair and equal opportunities. As we mature in our lives, we start to realize our own limits. And one of my limits is I am a linear thinker. I love theories of change that start at one point and go to another. And it's not that simple. So I try to broaden my thought, and I'm really trying to come up with a different way of looking at the theory of change. So these are the 3 strategies looked at differently. We believe that all good policy and program decisions have to be based on good data and information. Otherwise, you don't know what you're doing. You don't know what to prioritize. You don't know what to try to impact. And so that's the base. And then we have community partnerships that work with data and information in kind of both the downstream and upstream issues in health equity, but maybe a little bit more upstream. And then advocacy and policy comes from the idea that, almost all the inequities in our country come from policy, either intentionally or unintentionally, that impact disparities. I really firmly believe that. And you cannot take on health equity without taking on policy. Okay? So upstream, downstream, these are supposed to interact with each other, and they're supposed to feed on data and information, and then this is how we'll also know if we're making a difference. So data and information, systems are put in place to monitor health inequities and provide us the ability to do better programming and policies. Here's a slide from the 2014 CHAS release done by the Carle Health Institute that's just looking at the uninsurance rates by race and ethnicity in Colorado and the distribution uninsurance based on all Coloradans versus the uninsured. And it's ways of, again, looking at the disparities in healthcare access and availability that existed right before the ACA started expanding Medicaid and providing subsidized insurance, right? These numbers look vastly different in the last CHAS, right? Our uninsurance rate came down to about 6.7%. Thank you, Mike. CHI guys. Lowest than it's ever been since it's ever been measured in the state. Right? And those were the and honestly, that's what the ACA was primarily designed to do, and it did what it was designed to do. So this is just an example. So we hope to expand to think about high school graduation rates, limited English proficiency, community cohesion, affordability of housing, transportation to work, school, food, and worship. All the things that are part of life. So we'll expand this group, and we're working on that now. I talked about policy already, and the ideas that we'll research, develop, and implement to support health equity. And there our investment is really looking at kind of the RWJ approach to health, where we want to talk about behaviors in medical care, living and working conditions, economic and social opportunities and resources, and how our policies can impact that overall model. So our grant strategy there is something called a field building approach. We're using funds to support a cohort of advocacy organizations working together to achieve near and long-term solutions. And these are the outcomes we're measuring. They have a shared understanding and vision around health equity. They're increasing the diversity of organizations in the field, making sure that we're addressing the needs of vulnerable populations. We're increasing the capacity of organizations with how they complement each other in the field and supporting intentional coordination and collaboration among the field of groups that are looking at policies with a health equity lens. We have a number of different groups, and this is kind of a map of policy framework, and it talks about groups that are doing voter outreach and public education all the way up to lobbying and policy development and feedback. So what we've tried to do in this strategy is get diversity in the type of policy kind of advocates and the location of the advocates. And they come together, and it's fascinating to watch them work, because they said, well, tell us what you want us to do. And we said something that foundations almost never say. We said, no, it's not our field. We can't have a field. It's your field, and you have to build it. And given their choices and given the information they had to look at, they've really focused on things like racism as key items to understand and see how they work in policies. And they've had some successes, right? So they worked hard on the minimum wage increase issues. This year they were working to make sure that the privatization of the enterprisation of the hospital provider fee had disadvantaged populations in mind as it went forward. So they kind of protected and enhanced the status of groups that traditionally don't have voices in policy as that work went forward. And then finally, our biggest strategy, and probably most innovative, is our community partnerships. Communities have the ability to organize groups and act in a manner to promote and realize health equity. This is Institute of Medicine framework for multi-sector community engagement to achieve health equity. Okay, as a disclaimer, I helped write the framework, so that just tells you that it's right. Remember I told you about I'm a linear person? There's a linear version of this that I greatly prefer. And thank God I was just completely outvoted. So here's the social determinants. You see them all around the outside, right? And those social determinants, health, and we're looking at them within the context of inequities, biases, socioeconomic and structural drivers. And then the little type that you can't see says things like, you have to make health equity a shared vision. People have to buy into the concept. And then you have to improve community capacity to shape outcomes. You have to work across sectors because no one sector can do this successfully alone, with the idea that we'll create healthier, more equitable communities in which individuals and families learn, live, work, and play. And this isn't exactly the structure of the community partnerships, and it is exactly the structure of the community partnerships. So they were developed not at the same time. So I see a lot of old friends in the room, community-based participatory research folks. Dee, Montel, Don, I can be taught, right? We're conceptually similar to community-based participatory research, and in fact, two of us in influential positions, myself and Good Barley, our vice president for community partnerships and grants, both had a lot of work in CBPR. And the idea is that the communities are equal partners in the work. What a concept. Now, I know this is probably a choir room, right? So you're looking at me and saying, oh, there's nothing new about that. We do it all the time. You don't have to travel very far from this room to find people who think about it differently. Right? But that was the idea. And we want to authentically partner. I know that's aspirational. It really means we're really going to partner with you. But we're not going to kind of partner with you. It's a little different from CBPR in that we don't have a research agenda going in. We're not saying, I'm a cancer researcher. This has to do something with cancer or genetics or antibiotics. Or we go in and say health equity. Okay, that's a requirement. But think about the things I've told you. How can you not find something within the social determinants of health that's important to your community? And so they understand their assets, their problems, and they create their priorities and their group to work on the inequities. And the last thing I say is they're place-based, because I always get the question, what's a community? I'm not talking about a community of a certain group of people across the metro area. I'm talking about neighborhoods, places, because that's where the work and the partnerships occur. We shift decision-making to the community. So this is pretty radical in the philanthropic world. The traditional model is pretty straightforward. There are the foundations who have the money and the nonprofits who ask for it and do the work. Okay? And that's the traditional model. And so I would sit in a beautiful marble building a block north of the Capitol, and I'd say, ooh, I want to do health equity. And I would create an RFA about how to do that. And then your nonprofit would apply. Hopefully the mission would be close enough, your board would say, okay, we can do that. And then you would kind of do as best you could of what I told you to do. When we did our listening tour and I sat in communities, I said to myself, and I'm not casting, I don't want to undermine the value of what I just described. But the thought that I could sit in a marble building in downtown Denver and know what's going to work in Lamar, in Grand Junction, Cortez, Dove Creek, that's insane. And if you spend time in the community, they know what their problems are, and they know how to approach them. It was really revolutionary to kind of realize the power of community. So they choose which issue to address. They choose how they're going to address it. They need to say how we're going to measure success, so they're going to design their evaluations. They say what resources are we going to need and what's our path to sustainability. And the theory, which hopefully I'll be back in 8 more years to tell you, is that because they built it, they owned it, and they sustained it. That's the concept, that's the theory. A little novel, a little bit out there. People thought we were crazy for a while, and it's starting to take traction, and people are starting to pay attention. we do have a framework. The framework here is from the National Implementation Research Network. It divides community partnerships into 3: researcher phase, catalyst phase, and colleague phase. Now, when you design something as a framework and you implement it in the field, you are stuck with reality, right? So one of the things that we call ourselves a strategic learning organization is we kind of quickly found out this isn't quite right. And so we kind of changed the framework. And this is our current thinking. There's exploration, gather information, look at data, and look for opportunities. In a way, this is saying, where should we do the work? How to choose which community we should do the work. Because we're not saying, tell us if you want to play. We're choosing the communities based on data and exploratory work. And then we do early development where we use community organizing techniques like snowball techniques, right? So I go to Janet and say, I ask you about health equity in your community, and then I say, who else should I talk to? And you'll give me a list of names. And then I go to those people, and I always end with the phrase, who else should I talk to? And you build up kind of the expertise and the knowledge of who are the informal leaders in a community. And then the late development phase, or the development phase, is we actually create something we call resident teams. And the team prioritizes the areas. And I'll show you some of the outcomes of that work so far. And the team creates a leadership team, a smaller group of people who are really doing the work, and they hire the project staff. So the coordinator in a community doesn't report to the trust, they report to the resident team. So we've really pushed ownership, decision-making, and the approaches down to the community level. We have 9 communities here. It's like another learning opportunity for us. It's really where the rubber hits the road, and I told Frank, we're picking the rubber off the road every day, right? But how can they create a plan that we can actually implement? And then they'll do their evaluation plans and timelines. And then the last phase is implementation, a multi-year grant to help them achieve one or more priorities that the community has chosen. This is our core product that's supposed to interact with our other products. I just thought I'd give you some flavor about where the communities were about 6 months ago with what they chose. It's a remarkable list to me. It really is, because they're upstream. We didn't drive these. These are selected by the community. Youth and family support in forms of out-of-school programs, safe places and spaces, social recreational opportunities and activities, and child care. Then they've chosen education, housing, affordable housing, poverty and economic development and vitality, transportation, physical infrastructure, safety and environment, community building, cohesion and belonging. Oh, I love that one. It's like we used to be 90% Anglo, and now we're 50% Hispanic. And we have to come together as a community. And both sides recognize it. And then they turn to us and say, how do we do that? So stay tuned, because we'll figure it out. Culture, cultural advocacy, cultural retention, cultural revitalization. Great phrases, all mainly from the Valley, right? The San Luis Valley. Communication, and the Don, I had to throw this in there. In one community, their third priority was drug abuse. But it was more from the public safety and environment standpoint. Very interesting. Other than that, there is not a health care priority. And I'm telling you again, we didn't drive that. This arose organically. So I think it's an exciting list. Can't wait to see what comes next, and to come back and tell you all about it. So I'll leave you with our vision statement. All Coloradans should have fair and equal opportunities to live healthy, productive lives, regardless of race, ethnicity, income, or where we live. And with that, I'll open it up to questions. And thank you. Dr. Burke, are you asking a question?
Well, actually, I did have one. So the place-based community, I can see doing that, but that excludes other communities. So, for example, years ago when AIDS came along, one hospital I worked in, it was IV drug abusers, and another one, it was a gay community. Same diagnoses, two totally different diseases because of the way the gay community handled it. So why not these communities that don't actually have borders?
So the question is defining communities differently. I want you to understand that the model allows that, but it has to be a decision of the community. So if I'm thinking about the lower Arkansas Valley, highly challenged communities, right? Their only hope of sustainable solutions is to put apart their boundaries and to work regionally. And they have to come to that themselves. Otherwise, I'm imposing that from the outside. There will be groups that I think recreation is almost a marker for youth engagement and keeping the youth in the community. I think as we learn from that, they'll start to cross lines and look at similar solutions. Already, we bring them into Denver, the different coordinators and organizers, and they learn from each other in areas where they're doing similar work. So those broader communities will come up, and we're not going to create them. We're going to facilitate them. Great question. Yeah, over here.
Hi, my name is Sheila Davis. I'm the director of the Center for Health Equity Initiatives at the University of Denver. And my question concerns partnership priorities around what your partnership priorities are. And my interest is motivated by implicit bias training and culturally confident mental health care. And I'm asking this question sort of after the Orlando Castile shootings. And I noticed there's an article on your website about the mental health impact of these shootings on the African American community.
Well, let me start with mental health. That has to raise organically from the community. So if no community says we want to address mental health, we won't be doing mental health. Then I will say, I know it's going to come up. Because if you do a listening tour in Colorado communities, mental health comes up in every community. I can't explain why it hasn't come up in these, but some of it is I think they're a little bit more upstream. Then implicit bias. So you'd be interested to know that the advocacy cohort has really taken this on. And so they are undergoing their own diversity and inclusion training for every one of the organizations, including the minority-led organizations, because they've recognized this as a key part of the work that they want to achieve. We had originally thought about requiring that. It is so much better that they've come to that as their own conclusion. Pick their own facilitators and experts and are moving forward in the space. The communities are starting to work on that too. I told you about one community that recognized that they needed to come together across difference. The San Luis Valley communities have gone farther to bring in mediators, a mediator, to work between long traditional biases between Latinos and Anglos that have lived in their communities and their values and are dragging down the health of their community for years and years. So again, I get a lot of questions about what are you doing about, and you got to recognize that that's not the model. It's what the community rises up organically and out. And as they seek root causes, as we really push them, it's like we want to build a recreation center. Well, why? How's that achieve health equity? And we help them move down. Many of those communities are going to come to issues of racism and implicit bias and working across difference, I believe. Yeah?
Thanks, Ned. My question has to do with how do you get national experience or education into a community that may not start with it? If the community is designing, implementing, and doing their own evaluation, how do you make certain that we can help guide them with learnings that we've had from other communities? We wouldn't say, help you guys, they want to work on ASBET, and let them do that all themselves. We want to be able to learn from what's worked in other places. How do you help them?
Right. So it didn't come out in the slides, but that's our job, right? So if a group said we want to work on community mental health. We know we don't have the expertise. We pick one easy, education. I can't help you. However, we know who can. And so we serve that role in identifying a group of experts in the area that the community chooses among the group who they want to bring in to consult with. So the idea is they have to have outside expertise because they can't do it. And our job is that kind of, here's a list, here's who we know do this work, and then, and you're going to have to, if you want to be successful, it's going to have to come from outside of the community. And they get it, and they understand. So they do control the resources, and we're, I keep telling you, this is so innovative. We learn something every day, right? And so the communities we're wrestling with, we get access to this money, we could pay ourselves to do it, right? That's a trap, and helping them to see that they won't, will you be successful? Is that really, do you know enough to make this sustainable? And they make those turns. It's just really interesting. Yeah, Todd.
Ned, great talk. I was impressed when you had the slide up that showed kind of what had bubbled up in the communities in terms of the things that they wanted to address. How many of those were infrastructure kinds of topics and related? And I'm curious, was that where they got to eventually? Was that where they started? What was that process like? Because it wasn't programs, it was more infrastructure.
So you're getting into the sausage making of the extra experience, and I welcome those questions because they're interesting. But it's a level of detail that I hope everyone will appreciate. There's a very specific approach where every person interviewed, everyone on the resident team identifies what they think their priorities are. And then there's a structured pile sorting process where they look at intersectionality of the different items. I mean, they literally think about all of the things that people are talking about, and they see how they're linked. And they try to look for overlap, and they come up with a smaller set of priorities. And then they literally have to make decisions. So I talk about Fort Morgan a lot. Fort Morgan gives me rich examples, right? Fort Morgan's fascinating. For those who don't know it, it's a community that's been changed overnight by ice raids. So in 2002, with the ice raids, they devastated the working population of the Cargill meat packing plant, right? So all of a sudden, there are all these actually well-paying jobs, $18 an hour jobs, available in Fort Morgan, Colorado, and a refugee community in Wisconsin, who were looking for jobs, all Somalis. And the population of Morgan County went from 3 black people in 2002 to 20% black, almost overnight. And they were already 20% Latino. So remarkably diverse community, different cultures, different values, different languages. Amazing. And so the resident team that's been built represents all of the groups. And they wrestled with the fact that we said you could only have 3 priorities, and they had 6. So they said, well, okay, we're going to have education, affordable housing, and recreation. So those will be our 3. But we're going to look at all of those through community cohesion, belonging, and communication. So they took their other priorities and they made them into the context, right? So that's really how the work's done. And so when I put up something that was simple like looks like I lost it. Youth and family support, education, and housing. Those are they're more nuanced than that, right? So housing's fascinating because you think about rural areas and you think about affordable housing. You think about Denver, right? Big problem. Don't get me wrong. But they're having problems in Fort Morgan, and it's complicated by the fact that Muslims can't incur debt. So how do you buy a house without a mortgage? Right? So even these infrastructure pieces become more nuanced. And the recreation is really about how can we come together across difference, get to know each other a little bit better, and kind of counteract the negative messaging around difference about that's just another refugee or that's just another Latino. And so I use phrases that are like one-word phrases for their priorities, but I hope you understand that they're way deeper than that. Yeah.
So this is really exciting, but it's really outside of what public health students are trained in. So what is the role of local public health agencies in this model of work?
Great question. So I will drive you to the publication that had that framework in it. Communities in Action, Achieving Health Equity in Communities. It's on the IOM page. It's downloadable, so it's free. It is 403 pages long. I apologize for that. We had a public health person on there, the public health director for Chicago, and there's a hefty dose. It says you can't do multi-sector collaboration in communities without engaging public health. So it should make you feel warm and fuzzy. One of the issues is that public health understands population health. And the other phrase I always like is they know where the problems are. They may not have any resources to do anything about them, but they know where poverty and environmental challenges and infection rates and unsafe food, they know where that is in the communities. So they're important partners in the communities. It's a little bit harder in Colorado because of this basic, well-developed distrust of government. We have a heightened sense of that. That's been tailored by messaging from one side of the aisle since President Reagan. Very systematically, government's bad and I don't trust them. And capitalized on, I think, recently. A great book, Ian Haney Wilson, Dog Whistle Politics, talks about this messaging of creating this fear of difference and government's bad. So we're kind of challenged by that even at the local level. You know, it's terrible to be from, you go into some, I'm from Denver Health and I'm here to help you. You know how that goes in many settings. And looking for ways to engage public health and local government in the dialogue is really important. The other thing is they have the data, right? So all the community health assessments are a lot of the things we're looking at. And we've seen a change in community health assessments to start talking about things like limited English proficiency and high school graduation rates and really thinking about the social determinants of health. Now, what public health's role is in addressing those is yet to be seen. Yeah. Oh, I'm sorry, I had Dad, and then I'll come over here.
So Ned, in 8 years, 2025, when we come back to listen to you again, do you expect that in these communities you'll have demonstrably measurable better health? That all of this upstream work will have actually produced?
So great question. So thankfully, I've been fueled by my partner in crime in the California Endowment, Tony Ike. We will be looking at intermediate measures. The predictions are, what do we want to impact? Life expectancy. The payoff is 30 years from now. So yeah, 8 years from now, no. But 8 years from now, if Olathe picks affordable childcare, I'll be able to show you that they've created a project for sustainable, affordable childcare in Olathe. And that's an important metric. And then we'll start to look at other indirect metrics as we put together our social determinants of health indices on a community basis. And so there'll be a raft of, so what are the California Endowment measures? They have a project to reduce youth incarceration. And in 5 years, they've reduced the number of people, young men of color, being incarcerated by 4,000 people. That's in 5 years. So yeah, I believe that I'll be able to come back. By 2026, if we meet our projections, we'll be in 40 communities across the state, and we'll be winding up in our first 9. And I'll have something to show you. I will tell you there's some early successes, though, that I don't want to lose. Collaboration is a measurable outcome. And so Fort Morgan, I'll go back to Fort Morgan. Segments of the community are talking now that weren't talking before the trust came in. And so when there was a big walkout associated with the prayer hour, they actually had relationships between people who served on the resident team and the leadership at Cargill, and said, because of the work that we've done, we were able to sit down with those policymakers. And so these early wins are, figuring out how to measure them and what their return on investment is. That's a little bit harder, but I will tell you the communities are being transformed in important ways. I'm sorry, I came over here.
You put up the profiles of community members or individuals in communities. What role does understanding as a community member who you are and what you're up against, does it play in the success of this now and for the long term? And is there work being done around that?
So I'm not sure I exactly.
So if I fit one of those profiles, how important is it for me to know that? And how does that put me into action, or how can you inform community members? So, because all of this is being seen by a lot of us that don't fit into those profiles. But if you're a community member,
What
how do you
profiles
have
are you talking about?
the little girl, and the mortality rate for her infant child goes up because of her race and where she lives. How does community understanding those things help in this process? If I know that I'm a Latina and I'm 33 years old and I got a bachelor's degree, what role does that play?
I think what I would say is that you bring to the resident team the sum of your life. So I don't lead resident teams with this talk, right? It really is much more organic. And so a Latina, the head of the high school student placement program at Fort Morgan High School is a Latina. Mm-hmm. And she sees, and she's on the resident team, and she's on the leadership team. She sees her role as a Latina helping students of color achieve beyond what they would achieve without her help. She sees the barriers they face in the community to job training, higher education, placement, and income as a very personal experience for her. And she brings that to the table in the resident team to fill out that piece. The Somali leaders look at the housing and how they wrestle and how they put multiple people in a single dwelling room, and how can they be successful in building a family and enjoying the benefits of being in America if they face the barriers of housing that they can't do. And so I think what I would say is that the profiles of the outcomes isn't how people are selected or self-select. It's based on their desire to help their community and their lived experiences and challenges that they face. Yeah. Sorry, I wasn't thinking about the pictures. That really is just to try to define health disparities in a tangible way. Yeah.
How do you select the communities, and how does that process work?
Another great question. So I glossed over development phase, but it's mainly data driven. So we've worked with UCD and Debbie Main, who's sitting behind you, and her staff to actually paint social determinant portraits of different communities across Colorado. And so the first thing is that you actually see data evidence of inequity. And then we visit. So they call it a windshield tour. And they're really looking at the visual demonstration of separation of groups by resources. And those of you who've driven through small towns, if you're really good at being observant, you can spot towns that have greater demonstrations, physical demonstrations of inequities. And then they start talking to people. And you may end up with, and I don't want to name any communities, but you might move into a community who just, that whole phrase, health equity, or however you choose to start with, turns them off. And it may be so prevalent, the kind of the racism and white supremacy culture could be so strong that you might not find enough there to work with. And so you might say, well, we'll save them for later, right? Because you can't force this work on a community. And so they do that kind of early determination, and then they say, okay, we want to work in this community. And they all kind of started with, well, let's start in this community, and then they've already identified, so we're at 9, right? That means 31 more between now and 2020, and they'll use that same kind of process of kind of saying, who should we work in?
So it's easier almost to understand that when it comes to a town, like a Fort Morgan.
Great. So we didn't talk about urban areas.
Yeah.
So that's neighborhood based. And it actually, it's a pretty powerful thing. So there are neighborhoods in Denver, right, that have, and I know the borders are a little blurry, right? 2040 knows this, right? So when I say the Montbello neighborhood, it actually has lines on it, right? The map I showed you of Denver, that's a neighborhood map. The lines are a little blurry, right? But people kind of know where the heart of that neighborhood is. And so in Denver, we're working in Montbello, in Sheridan, and are starting to work in Aurora. And I get nervous because the community partner working there says Aurora. That's all. But I know she'll come into focus. And in Colorado Springs, we're working in Hillside and in Security. And so areas that really have a defined neighborhood. Hillside is the last black neighborhood in Colorado Springs. And it's in deep danger of gentrification. They just lost their elementary school. Very bad thing to have happen in communities. And so it'll be interesting work. Yes, Sarah?
Can you talk about some of the key steps in the trust's process of transformation to take this new approach to funding? Some of what felt like those seminal either activities or decisions or learnings through that process.
Don't be faint of heart and be persistent. That's been the biggest issue. Our board was like any other foundation board. They were brought up in the old model, and to convince them to do it differently. I'll never forget when I first brought up this concept of letting communities decide, and one of the board members, who at the time, he was a physician, well, he's still a physician, and he said, "What? We can't let communities decide. I mean, what if Pablo said the way we want to address diabetes is to get more endocrinologists?" And I paused to beat and I said, "Yeah, and what if that worked?" At the time we had a requirement of a number of physicians that we kind of worked through because social determinants don't need doctors, right? But the doctors wrestled with this, because we're present company excluded. We're kind of taught to say, do this, right? So there's a certain amount of paternalism in how we approach patient care. And I'll make the decisions that are good for you. Now, we're in family medicine territory, so we're much better at that. But getting the docs to say, yeah, this could be something. I mean, it was really interesting. The hardest part was our staff. Because program officers are kind of like little foundations. And they had who they liked to fund, and they liked the projects they were doing, and they didn't want to change. And they were good people, and they were good program officers, and they just couldn't make the transition. And so that staff is gone, and that was, for someone who is just, on most days, a really nice person, that was pretty agonizing. That was really painful. But it's that thing is we had to have the right people on the bus to do this work. So we've emerged stronger, more united, more cohesive, and with probably some little pockets of the old foundation thinking, we're all on board going in the same direction. And it's been a journey, yeah. That I feel is almost over. Yeah. Thanks for asking. I mean, that's a personal, tough question. We did do diversity and inclusion training. And we did it for all staff, and we're still doing it. And I got my board to do it. And I tell you, that can be really remarkable. especially if you don't believe you're a racist. Okay, sorry, Frank.
Oh, thank you, Ned. Thank you so much.